Welcome you all for today's interesting session on neuroimaging in epilepsy. As we all know, imaging plays a vital role in the evaluation and management of children with epilepsy. It has become one of the key pillars in the diagnostic evaluation of children with refractory seizures. An elegant structural neuroimaging with MRI often assists not only in determining the etiology, but also it helps to identify the structural changes, anatomical changes associated with epilepsy. Today, Bijoy sir will be discussing about the importance and utility of neuroimaging in epilepsy. I would like to introduce the moderator for this session, Dr. Raghavendra, Associate Professor of Neurology from NIMHANS, Bangalore. Sneha.
Thank you.
Dr. Raghavendra has done his MBBS from Bangalore Medical College and MD Pediatrics from PJ Chandigarh. He has completed his clinical fellowship in neurology from Bangalore Medical College and DM from NIMHANS. He also has completed postdoctoral fellowship in clinical epileptology from NIMHANS Bangalore, and also has done mini fellowship in the Epilepsy Center of the University of Munich, Germany. His fields of interest are pediatric and adult epilepsy, electrophysiology, quantitative neuroimaging, biosignal analysis care, computational neurosciences, biosignal and medical image processing. Over to Dr. Raghavendra.
Thank you, ma'am, for that generous introduction. Today we have a esteemed speaker who is going to speak us or take us through the take us through and enlighten us about the key methodology involved in management of epilepsy, especially in children where there's a dynamic brain both functionally as well as structurally. So it gives me an immense pleasure to introduce the esteemed speaker of the day. That is Bijoy Thomas sir, who is a professor and head Department of Imaging Sciences and Interventional Radiology, Sri Chitra Tirunal Institute of Medical Science and Technology. So he holds a three-figure international publication and has published has edited many chapters as well as have been written many book chapters. He holds a clinical fellowship in pediatric neuroradiology as well as a fellowship in functional neuroimaging. He has four-figure citations, including a H index of 31. He's not only a right brain person, but also a right hemispheric high functional individual. As you can see, he's interested in oil and acrylic painting. So now that I'm exhausted with the introduction to sir, I'd like to call him upon to take it forward with his talk. Thank you.
Thank you, Dr. Raghavendra and AOCN for this kind introduction and also for this opportunity. So I hope you can see my screen.
Yes, sir.
Yes, sir.
And I'm audible also. Thank you. So today, the next hour or so, we will be discussing about neuroimaging in epilepsy and mainly pediatric epilepsy. When I say pediatric epilepsy, we will not be covering neonatal and very young infants' brains. These are my disclosures. And the objectives of the present talk is actually to review the current protocols in epilepsy imaging, pediatric and adult, and discuss the most relevant pathological substrates of intractable epilepsy in children and their imaging appearances. To discuss the role of imaging in epilepsy surgery decision-making process. So like I've told, we will not discuss this neonatal epilepsies. And the main role of imaging, especially in the surgical workup of intractable epilepsy, is to diagnose, categorize, and select patients for therapeutic planning, including potential resective surgery. So imaging should be always interpreted in correlation with the clinical and electrophysiological data, as I will exemplify with the several examples. And it is always a multidisciplinary approach because if it is reported in isolation, most of the time, the pathology you are actually looking at may not be the culprit for the epilepsy. So there are several classifications. We will not go into the classifications as such, but this is probably a functional classification which may be useful, especially in pediatric population, in intractable epilepsy syndromes. You can see that which are potentially curable by resection, like mesial temporal sclerosis, focal cortical dysplasias, dysplastic tumors, or long-term epilepsy-associated tumors like DNET. And then conditions like focal gliosis, etc., which which are potentially curable by resective surgery. So when we are talking about drug-resistant epilepsy, then there will be several neurocutaneous syndromes and several epilepsy syndromes where resective surgery may not be an option, but a diagnosis, especially, for example, tuberous sclerosis, for example, there are newer therapeutic options getting available. So the diagnosis is really important. And the third category, like inborn errors of metabolism, large post-encephalitic sequelae, which are not at all possible to be cure of epilepsy by surgery may not be possible, but sometimes there may be the palliative surgical procedures may be possible in these, and which can be decided based on the imaging appearance. So with that, there are several caveats for imaging as well. So we see that the 10 to 40% of children with epilepsy have medically refractory epilepsy. And despite all advances in imaging, around 50% of them still remain cryptogenic in substrate identification by MR. So why we need to diagnose a substrate or detect a substrate by MRI? Because once you detect a substrate by MRI, the chances of a cure or a significant improvement in seizure outcome is much better compared to when you are not seeing a substrate and blindly operating or operating only based on electrophysiology and other data. So MR forms, the positivity MR finding forms a very important predictor of outcome of these intractable epilepsy, especially focal epilepsy syndromes. So in the preoperative evaluation, we know that it's a very tedious process. I don't have to elaborate on that because most of you are neurologists and you know how elaborate these processes will be. We will be discussing mostly about the imaging aspect of it, how it is important to identify a substrate, and how to prove that the substrate is actually responsible for the epilepsy, and potentially looking at the epileptogenic zone and the seizure onset zone. Now, with the advent of the evolving concepts of epileptic networks and nodes, and this is also changing dynamically. We have to dynamically image the process or epileptogenesis as a process, and more advanced imaging features are getting incorporated into epilepsy pre-operative evaluation. So, in addition, imaging may be useful in not only identifying the substrate or in the most advanced cases, the networks and nodes, but also establish a surgically treatable condition from a non-treatable or a partially treatable condition. And also it will be useful for predicting the outcome and also in the post-operative imaging if the outcome is not as we expected. So today, these are we will discuss these in 10 rules in epilepsy imaging. These are just for sake of understanding. They are not rules by ILA and all. So most of the time as a diagnostic neuroradiologists, we will be forced, especially from our neurology colleagues, send us images through all media, including mobile phones. But when you're talking about epilepsy imaging, especially in the preoperative evaluation, we should actually do diagnostic quality DICOM images and visualized on a enterprise quality diagnostic monitor, not even on a simple computer monitor. So if you don't have a Barco or a similar medical grade monitors, at least you should, it's a very high-end display monitor. But most of the time what happens is that we will be forced to look at images on WhatsApp, especially scanned images. So if you're seriously looking for epilepsy imaging and especially preoperative evaluation, you should avoid such practices, but most of the time we'll be again forced to look at initially, at least as a preliminary measure. So second important thing is that the sequence optimization is the key. And it is found that if you are looking at the general brain imaging protocol, at least 50% of substrates can be missed. And if it is also training level of the physician is very important. So if it is actually looked by a general radiologist, the chance of finding a subtle depth of the sulcus dysplasia is very, very low. So again, the sequence optimization, the MR equipment you are using, and also what is the level of expertise of the reader is, everything is really important. When you talk about the expertise, it's not only the visual expertise, but how much you are actually attending the pre-epileptic meetings and the patient management meetings, and how you are actually correlating the clinical and electrophysiological data with your imaging findings. For example, if you have a 3 Tesla, and nowadays 3 Tesla is preferred for all epilepsy imaging, especially pre-surgical evaluation. We see that when we optimize a high resolution T2, we can actually see the internal architecture of the hippocampus very well. So because there were the protocols were not uniform throughout the world, in 2018, the harness protocol was suggested in this epilepsy paper, and which is a very simple protocol, but it requires to be done in a very standardized manner. So basically looking at 3D T1 sequence, 3D flare sequence, and a coronal high resolution T2 sequence. So this is why 3 Tesla is preferred, because the 1.5 Tesla, there is a high chance of actually missing the lesion, or a 3 Tesla detects a lesion almost more than 2.5 times better. So another very important thing is that when you are looking at children, especially very young children, the optimization, especially of the T2 and the T1 value is very, very important. So we have to probably increase the especially when you are looking at the T2 weighted sequences much higher compared to an adult protocol. So we found that this harness protocol, even though it is a basic protocol, which will suffice most of the cases, 2 additional sequences may help a lot. That is the arterial spin labeling, which we'll talk about a little towards the end of this talk, and also the susceptibility weighted imaging, because in India and many parts of the world, much of susceptibility areas, including calcium and blood products, may be contributing to the development of seizures. Advanced imaging may help in the detection of, in helping the epilepsy surgery, especially mapping the eloquent areas, and also more so with the resting state networks, especially in detecting the epilepsy networks and nodes, even though it is more of experimental nature even now. So when you are actually planning these sequences, the 3D sequences you can plan, and you can actually reformat it in any plane. But when you are looking at the T2 coronal high resolution sequence, it should be perpendicular to the longitudinal direction of the hippocampus. So we have to plan perpendicular to the hippocampus direction that you're. So this is how 1.5 Tesla will be different from 3T. You can see the same image. This is in 2005 or prior. You can see even then, you can see that there is a dysplasia here. In addition, a large developmental venous anomaly, which is very well picked up on a 3T, not on 1.5 Tesla. Even if you are doing 1.5 Tesla, this is a 3D flare in a 1.5 Tesla. If you do high resolution and reformat it in multiple planes, you can actually detect a depth of sulcus dysplasia like this. So looking at carefully all these images, taking some time, and looking at the been correlating with the electrophysiology and the clinical semiology data may be very important. And these curve planar reformats may be useful to show the surgeon where exactly the extent of the lesion. But if you are going to diagnose, you are going to diagnose on routine coronal axial images. So coming to the focal cortical dysplasias, which you are all aware of the ILA FCD classification. The type 1 dysplasias, which are again subdivided into 1A to C, depending on the abnormality of the cortical lamination. And the type 2s to A and B, where to A there is a dysmorphic neuron cell alone will be present, where 2B is a Taylor's balloon cell dysplasia, where dysmorphic neurons as well as balloon cells are present. And the 3 when it is associated with other pathology. So 2018, there was a review on this, and this is how the Neuenstein, the pathologist is looking at the cortical laminations. So this is a normal 6-layered cortex, and this is the case where you can see this cortical lamination is lost. And though pathologically may be easier for them to diagnose the type 1 dysplasias, the type 1 dysplasias, cortical dysplasias, are extremely difficult to be detected on MR imaging. What we can very clearly detect is this type 2B dysplasias most of the time, what you call a Tyler balloon set dysplasia. You can see this large cortical thickening and the deep running sulcus, and also a transmandible hyperintensity extending up to the ventricular margin. So where you can see the balloon cells as well as dysmorphic neurons in the resected specimen. So this is another focal cortical dysplasia. Sometimes you can see this transmandible hyperintensity, where it will be rich of balloon cells as well, can show T1 hyperintensity. Because basically probably because of the hypermyelination, other gematocytic accumulation and all, because of the increased electrical activity there. So looking at carefully or both on T1 and T2 weighted images, you usually will not miss focal cortical dysplasia type 2. But when it is type 1, especially in the temporal lobe or in the frontal lobe, where there is only a depth of the sulcus, abnormal deep sulcus with a very subtle focal cortical, cortico-medullary differentiation abnormality, may be extremely difficult. And usually with the clinical and electrophysiological pointers, you have to see carefully several times back and forth and to detect these dysplasias. So this is the Neuenstein. You can see that again, the very dysmorphic neurons, and this is the H&E stain, where you can see these dysmorphic neurons and the dysmorphic neurons, and in addition to balloon cells as well. So this, when you see only dysmorphic neurons, it will be type 2A, and when you see both, it will be type 2B. And most of the time, what we see as a with a transmandible sign will be a type 2B. Having said that, there can be dual or double pathology. When you are like Professor Barkovich always says that what is most difficult in clinical neuroradiology is actually to find out the second lesion. For example, in this case, the patient has got a amygdalar hyperintensity hypertrophy. You can see this uncus is actually bulging in. And if you see, compared to the opposite side, this amygdala has got a slightly brighter signal intensity. And in addition, you can see the neocortical temporal changes are also there. And the hippocampus is showing loss of internal architecture, loss of digitations of the hippocampal head, and atrophy and hyperintensity. So the hippocampal hyperintensity can be associated with an amygdalar abnormality as well as neocortical changes. Sometimes can be associated with the cortical dysplasia of the amygdala, or otherwise there can be only neocortical changes which may be showing a neuronal loss and not much of a myelin loss. So the third rule is dysplasias are chameleons and they can change colors. That means they can actually change shades of gray. So depending on the age of the child and the myelination pattern, dysplasias can actually change shades. And sometimes it will be extremely difficult to detect them on MR imaging, especially when we are actually not careful in looking at them, and when the clinical details are not clearly known, especially when they are very, very young. You can see this is a child, 11 month. So you can see that the right occipital lobe, there is a poor gray-white differentiation, and also it is slightly bulky. And you see the T1, you can see that the optic radiation is well myelinated on the left side. On the right side, you see there is the T1 hyperintensity optic radiation is dismantled, or it's not well formed. And the poor gray-white differentiation, the gray matter, white matter differentiation is not clear on the right occipital region. Whereas in coronal T2, it is even more subtler. It is very difficult, and you can see that the myelination is not complete here on the right occipital lobe. With the same child at 2 months of age, you can see that it is much more difficult, especially on T1, to differentiate that whether there is an abnormality on the right side or not. But in T2, this is more obvious. So the T1 and T2 appearances of dysplasias can change depending on the age of the patient. So another thing is that when we are sometimes sure that it's a dysplasia, not all things which look like dysplasia may not be a dysplasia. This is a female patient presented with intractable seizures. You can see that there's a left occipital lesion, and this patient had a very high seizure burden. There is a hyperperfusion, most likely is the postictal or a periictal hyperperfusion. And you can see even lactate there. So this could be very different differentials for this appearance. This could be an underlying dysplasia with a postictal phenomenon. This could be a Melas disease. This could be an autoimmune disease. A lot of differentials can actually present like this. So after some times, the patient with treatment, there was some improvement, and you can see the disappearance of this lesion. So again, the differential diagnosis could be this was just a postictal. There could be an underlying dysplastic lesion. And the patient other workup, for example, of Melas as well as workup was negative, and this was proved to be an autoimmune encephalitis. And this is another case. It's a young 9-year-old male. You can see patient had intractable seizures, especially EPCs. And you can see in the initial scan, it is very difficult to find out which side is abnormal. But progressively, if you very carefully see that the left side frontal lobe, especially this gyrus, is little swollen. And later, in 2 years later, you can see that there is hemispheric volume loss. Sylvian fissures are wide compared to the other side. The ventricle is also, lateral ventricle is larger on the left side. And this is in another 2 years. You can see the ventricular dilatation is more prominent. Cortical hemispheric atrophy is more prominent. And this is the arterial spin labeling perfusion. This is a perfusion study. You can see that there is hemispheric hypoperfusion, but there is an island where there is hyperperfusion. So this is what we see in Rasmussen's encephalitis. So we recently published on this also. Even though even in the dying out phase, when there is a significant atrophy of the hemisphere, there will be islands of cortex which will be firing and which will show hyperfusion, which could be due to an increased electrical metabolic activity or due to active inflammation. So this is we have recently published on this. And the fifth rule is you have to know your sequences well, when to use what. And because this hippocampus, I've shown you this hippocampus and the internal architecture of the hippocampus. And this is how the hippocampal, you are all familiar with the cornomonis and the different parts of the cornomonis, CA4 to the CA1, and then continuing as the subiculum and the parahippocampal gyrus and all. So this is with a high resolution, you can even get the all similar section, what you can actually see in the nuance stain, even though you are not seeing the neuronal loss per se, but you can look at which specific part of the hippocampus is atrophic, and then depending on that, there is different classifications. So another very important, interesting finding is that these are the basic findings. So when you see this significant atrophy, hyperintensity, everybody will diagnose hippocampal sclerosis. But to detect it early, like the loss of early digitations of the hippocampal head, or early subtle hyperintensity or loss of internal architecture, which I've shown previously, are very subtle signs which may be picked up early and which can be appropriately treated. Another very important sequence which many neurologists, epileptologists like is this T2 relaxometry, the T2 time value calculation of the hippocampus, so that they can early diagnose which side is abnormal, if there is symmetrical or asymmetrical involvement, which side is more involved, and is there a burned out hippocampus and all. So when you are looking at this, you have to be very careful that it's also heavily technique dependent. You will be reading a particular paper and you will think that the reference values are universally true, may not be, because 1.5 Tesla and between 1.5 Tesla and 3 Tesla, the T2 values shorten, T1 values increase. So what we see normally as up to 110 or 100 and 105 milliseconds as normal on hippocampal T2 value on a 1.5 Tesla may not be true on a 3T, because 3T, the T2 values will be much shorter. So less than 100 or 95 may be a normal value. So 105 will be quite abnormal, but compared to 1.5 Tesla. So another very important thing is that we have to narrow the window and see whether early to pick up the early findings. So when you narrow the window, you can see that the hippocampus will be bright, but the opposite hippocampus also is slightly bright. So that is because the hippocampus is not having its 6-layer cortex. It's an old cortex, like the insula as well as the cingulum. So insula, cingulum, and the old cortex, the paleocortex will be brighter compared to neocortex, for example, here. So this is a normal appearance on FLAIR. So if you normally look at a FLAIR image, you will not differentiate this difference. So if that hippocampus is brighter than the opposite insula or opposite hippocampus, then this is abnormal. So we have to be very careful about this appearance as well. So the one learning point is that normally the paleocortices, that the 3 or 4 layered cortices are hyperintense on FLAIR, like the cingulate gyrus, whereas immediately superior gyrus, superior frontal gyrus is not that bright. So if you can see this difference only if you narrow the window and see. So another very important finding is that so when we look at the image, as radiologists, we look at the image first before looking at the correlating with the clinical data. So when we look at this, we see that compared to the right side, left side, there is hippocampal digitations are lost, and you can see the internal architecture is lost, and this has got an abnormal orientation of the speculum, and you can see that this left hippocampus is abnormal. The parahippocampal collateral sulcus is abnormally oriented. So we were very sure that this is a left hippocampal pathology. But the neurologists asked us to look at the images carefully again, but we found that then the seizures are coming from the right frontal and cingulate region. So you see that when you see carefully, there is an abnormal deep sulcus there in the anterior cingulum and cingulate gyrus, and also with a poor gray-white differentiation. This is an area where normally normal gyrus can look like abnormal, because the gyrus is actually taking a curve. If you are actually cutting it across, you will always think that the cortex is thickened. You have to be very careful. You have to see at least in 2 or 3 planes. Here you can see that the gray-white differentiation is abnormal in 2 planes, and also the ASL and other sequences may be useful in this case. In this particular case, the electrophysiology is pointing to the right anterior cingulate region, whereas this is actually an incidental or a pathology which is maybe a pathology which is not actually contributing at present to the electrophysiological data of the patient. So they're correlating always with the pathology, I mean, with the physiology as well as the patient's clinical data is very important, rather than jumping into conclusions on MR imaging alone. So when you are in doubt whether we have very different armamentarium to look at, because these things are not routinely used, but for example, spectroscopy, this is a spectral color map, which is done on 1.5 Tesla. You can see that the anterior to posterior, there is a gradient, a choline gradient from in the hippocampus head to body. So you see that from in the normal hippocampal head, the choline levels are higher compared to the tail region. So NA is just the opposite. The anterior head of the hippocampus, the NA is lower compared to the body and the tail of the hippocampus. So this is the normal distribution, and this is the normal distribution of NA, and this is hippocampal sclerosis. We can see NA is reduced, not only in the head region. So normally NA will be lower in the anterior hippocampus and the uncus region. But if you are actually comparing the opposite side, you can see that the body and the tail region also NA is reduced. So that is abnormal. So if you are comparing head to head, the oranges should be compared with oranges. So it's having said that, this is not routinely used because it is extremely difficult to get good quality spectrum from the hippocampus. So, but you should be aware about this normal distribution. So the other advanced techniques like segmentations we have published this quite some time back, I think almost 10, 15 years back, looking at the computer aided assistance or detection of focal cortical dysplasias. Those days, artificial intelligence was not in vogue, so we could only find out a lot of lesions which were they either false positive as well. But however, if you can see that presently with the advent of machine learning, we can actually reduce this false positivity rate to a much higher level. So the sixth rule is that when you see nothing, look really, really hard. Because like I've told in the start of this presentation, a positive MR appearance is really, really important, which detects, which decides the patient's outcome surgically. So for example, this is the people are very sure that this is a temporal origin seizure. When we look at the routine imaging, we are not seeing anything. There is no hippocampal sclerosis. The gray-white differentiation of the temporal neocortex is normal. But so when we look at the T2, we had a doubt. So we did this high resolution T2 CIS 3D imaging, or very high. These are very high resolution T1, T2 weighted sequences. You can see that there is a herniation of the temporal lobe into the sphenoid, or not in the sphenoid, in the floor of the temporal middle cranial fossa on the right side. So this is a case. You can see that if you do the CT, high resolution CT, you can see there is a defect, and it is actually in the case. You can see that the temporal lobe is actually herniating medially into the sphenoid. So this is another case. You can see this the encephalomyelocele is actually herniating through, and you can see there is a gliotic brain along with the CSF and dura is herniating through. And resecting this may give the patient seizure freedom. Another very important finding you should never miss is that the hematoma of the hypothalamus, and if it is very small, especially sessile ones, can be missed. And should always look at, even when you're sure about one pathology, should always make sure that you look at the hypothalamic region, and not always they present with the gelastic seizures. So again, another case. Can you tell me where the lesion is? So again, the clinical data will be useful. The neurologists are sure that it is from the frontal lobe. When you carefully see that between the gyrus rectus and the orbitofrontal gyrus proximally, there is an abnormal mass of gray matter, and here you can see that this gray matter can be detected. So if you are casually going through the hundreds of images slices, because we are looking at 3D T1 and the flare and coronal T2 sequences, and so if you are not very careful, you can actually miss that. So another pathology, like you're all aware, the anterior quadrantic hemimegalencephaly, and you can see another really important finding. When you look at this, you should also look at the olfactory bulb on the same side, because olfactory bulb is nerve, is not a true cranial nerve, it's an extension of the brain. When there is anterior hemimegalencephaly or a dysplasia of the cortex, most of the time the olfactory bulb also will be hypertrophied and increased in size. So hemimegalencephaly, we know that it is associated with many syndromes, many cutaneous malformations, and you can see that this is a case which we followed up from fetal. There was significant increase in size, which was even enhancing in postnatal period. Later it went on to atrophy. So epidermal Nevel syndrome, tuberous sclerosis, a lot of other conditions can be associated. Sometimes you will be carried away by the large mass malformations, but you should also look at the other areas. For example, this is a tube A1A mutation. You can see multiple cysts and also abnormalities of the brainstem is another case. We can see the abnormality of the brainstem and the cerebellar vermis. So in these cases, genetic workup may be more important than looking at the surgical implications. See, these are many other pathologies which we will not go into the details. Again, look carefully. When you are seeing nothing, you should do spectroscopy, like we have shown in this case, where the congenital creatine transporter chain deficiency, and sometimes may be treatable. Not all cases treatable with creatine and other supplements. So the other pathological substrates, long-term epilepsy-associated tumors like gangliogliomas, as well as DNETs. We have seen a new WHO classification, new tumors are also getting added to this, like MENT, and which may or may not be associated with seizures and other tumors. And one very important lesion, which is seizurogenic, is cavernous angiomas or cerebral cavernous malformations. Again, other syndromic conditions like Sturge-Weber syndrome and another condition where particularly where you can see hemispheric abnormality with vision can present with seizures, as well as when you carefully see that there is a frontal scalp is missing, and this is Parry-Romberg syndrome. And another case of Parry-Romberg where you can see again hemispheric multiple microbleeds or calcifications with the focal hyperintensities or pseudotumors and enhancement. You should always look at the scalp as well as the frontal skin, and you can see even on imaging you can find out the scalp defect, and the Parry-Romberg syndrome or a linear scleroderma can be diagnosed. So again, to other conditions, again, if you look carefully, the ASL is giving you a clue that the perfusion is high in the left frontal region. And you can see that the cortical, if you very carefully see that between the right side and the left frontal lobe, there is a significant poor graver differentiation, cortical thickening, left frontal lobe. We found that we thought that it is a type 1 focal cortical dysplasia, and this is an increased perfusion. Also there, we thought this is type 1 dysplasia, but after resection, it turned out to be Mogue, and which is mild malformation of cortical development with oligodendroglial hyperplasia and epilepsy. So different pathologies, sometimes we can be taken into surprise. So one of the last rules, the 7th rule, is that ASL is your friend. And it is a very important sequence as far as we are concerned, because we picked up many cases which we thought that MR negative with this sequence. But we have to be aware of some of the pitfalls which can happen on this sequence as well. So we can see the interictal hypoperfusion, periictal hyperperfusion, and it can be comparable to SPECT and PET, and it is ASL is called a poor man's PET. So you can see that there are several papers on recently on ASL as well as PET studies on epilepsy substrate evaluation. Recently, we have published on ASL many papers, including this paper. We can see that this is a frontal FCD. You can see that the left basifrontal already poor graver differentiation is there. And you look at this is what I told you should always look at the narrow window. You can see this dysplasia very well and not in the normal window. And you see this ASL, there is a subtle hypoperfusion compared to the opposite side. And this is the PET study. You can see the PET study, hypometabolism. So the hypoperfusion and hypometabolism are different physiological phenomenon, but they are related. That's why you will get that this appearance that ASL can be used as a so there were some questions. I think I will answer those questions last for the interest of time. So you can see that what I wanted to say is that so whatever is actually hypometabolic on PET, when the interictal phase that you can see that ASL is also a similar appearance can be found. And this is hippocampal sclerosis. You can see that the left hippocampus, you can see compared to the right side, there is a hypoperfusion on ASL. So whereas in the ictal phase or immediate peri-ictal phase, you can see the hippocampus is showing high perfusion. And this is the case. Initially, we were looking at the flare sequence. We didn't find any significant abnormality. But when we looked at the flare, I mean the ASL, we found that there is a hypoperfused area. Usually in the occipital lobe, because of the visual activity, the occipital lobe, there should be significant perfusion increase. Whereas in this occipital, there is a hypoperfusion which is abnormal. So when we looked at this image again, so this is the flare. You can see this is a narrow window. You can see this cortex as well as underlying white matter is abnormal. So very subtle gliotic areas where when there is intraictal hypoperfusion, ASL is detecting these lesions much better. So again, this case patient had intractable seizures. Which side is abnormal? So if you look at in the normal windows, it will be all okay. But if this is the ASL image. So now which side is abnormal? Whether this is right-sided hyperperfusion or left-sided hypoperfusion. So again, the clinical semiology as well as electrophysiology will give you a clue. But again, if you look at narrow the window, we can see this neocortex is abnormal, swollen. Like I previously told, the insula can be bright normally, but this is much brighter. But here the neocortex is also, temporal neocortex as well as the frontal neocortex is also abnormal, and this is abnormality. So this is another case, the young child with right frontal seizures. So the previous MR imaging was normal, and we see that there is a lesion there, right frontal operculum, and you see this is the right frontal operculum, and this lesion, initially it was thought that this is again a focal cortical dysplasia, but one initial MRI was negative. And so you can see this is the PET study. So this PET study at this time showed hypometabolism of the right frontal lobe, whereas when we imaged this patient at a later stage, patient had immediate seizures, and you can see the right frontal operculum and the immediate adjacent areas, there is increased perfusion. So this is an interictal PET and it is ictal ASL. We can see that it is also correlating to the same area, because it was previously and later this child was proved to have a autoimmune encephalitis. So focal lesion, not all focal lesions I've told is that not due to focal cortical dysplasias. Another very interesting important finding, when we see this post-ictal phenomenon, we always attribute that this may be the site, this may be the locus, this is the epileptogenic zone. May not be always true. For example, this case, there is a march and the epileptogenic focus was much anterior, because we have actually caught this ASL imaging much later. We are actually seeing the hyperperfusion in the posterior hippocampus. So it is not like SPECT imaging when you are actually injecting, it is actually going and there is a ligation and then it is fixed to that area. So ASL, it is a dynamic process. So the ASL hyperperfusion may not always correlate to the epileptogenic zone, but it can even represent a Jacksonian march. For example, this case, bilateral occipital gliosis, here the epileptogenic zone was electrophysiologically proved to be the right side more than the left side, but you're again seeing the hyperperfusion on the left side. So this is some of the pitfalls you can see in this case, young child under anesthesia. We can see that there is significant hypoperfusion of the left hemisphere. So we don't know which is abnormal or not, but when we looked at this, you can see that the pilot tube of the intubation tube, there was a small spring there, and this spring is on side. Because of this, the ASL tagging is not sufficient here. That's why this artifact, and when you tape it to the center, this perfusion comes back. So you have to be aware of these artifacts as well. And the third thing on the eighth rule is that so the eighth rule is that if there are questions, I'll definitely answer at the end. So the eighth rule is that the sonography is very versatile, especially in the preoperative and with navigation. So we are a resource restricted nation. So most of us will not be able to afford a perioperative MRI, but perioperative ultrasound, I think most people can afford, and we should utilize maximum this opportunity. So most of the neurosurgeons, when they ask how they find out focal cortical dysplasia, the extent of the focal cortical dysplasia, most of the time, which will be much larger than what you see on MRI. So they palpate the brain, and depending on the rubbery nature of the brain and it is the hardness, they find out whether this is normal brain or abnormal dysplasia. So it's a this is really important to differentiate this, and with the ultrasonography we can actually see there is no need for palpation. We can actually see this. For example, this is a type 2B dysplasia. You can see this abnormal brain, the transmantle sign. This is the preoperative ultrasound. This is not how you see this, because I have actually flipped it to match the brain MR appearance. You can see this is the dysplasia. Dysplasia is very clearly seen. You can see this echogenicity, which is different, and also it is going in. So the surgeon can remove it with a small burr hole. They've actually removed it. This is the postoperative cavity, and with the surgery is over in 20 minutes, and you don't have to palpate and blindly go. So once you see this, this probe can even be navigated, can be superimposed on the brain image. So with the radiologists there, it's a matter of seconds before the complete resection of this cortical dysplasia is there. So this is how, this is another case. We can see this another pathology. This is the how the resolution of neurosonography, and which is very useful. The ninth rule is always look out for innovations. There can be simple solutions for complex problems. So when you see this paper, we have published quite some time back, looking at the Mays loop, how you can prevent blindness or quadrant anopias in temporal lobe resections. So if you look at this paper, not many people use these techniques because it is very cumbersome to use this. They use standard resection techniques, and most of the time, the patient will not have a visual defect. But when they have to extend it because of the pathology, extension of the pathology, or a dual pathology or double pathology, you need to do these advanced sequences looking at them. But with this new QSM and SWI and path processing and all, we can see with this myelin also is showing susceptibility changes. You can see the Mays loop, and if you appropriate nip it, you can see this optic radiations in Mays loop very clearly. Even on, there is no need for a DTA tractography. Another very important thing is that previously, when we used to do all these grid placement and all, we used to do 3Ds and then superimpose on drawings to find out where exactly it is superimposing. Now we can actually do all these things very easily. We can even co-register this on MR, and with this all new software, it is very easy. And also we can even 3D print this. So other things like diffusion tensor imaging, which I talked previously, all these things are now feasible, but most of the time surgeons, not many surgeons would like to utilize them to the extent that we want them to utilize it, because epilepsy surgery is very dynamic, because when they go there, they cannot actually say that before saving these very elegant cortices, they have to get the patient, their preferences will be to get complete seizure freedom, not like a tumor resection or other pathology resection. So another very important thing is that functional MRI, especially for the language lateralization, and you can calculate the laterality index, which I've shown. This is a young child with a left front focal cortical left frontal FCD, and unfortunately the language is also lateralized on the same side. So this is tumor with again Wernicke's areas is more, language is lateralized more towards the same lesional side, left side. And WADA test, we found that also in our studies as well as in several other studies, that it is correlating very well with the WADA. But when there is actually a concordance, most of the time what expected, they don't go for a WADA test because it is more invasive, and most places they don't do a WADA anymore. And but especially in very young children, it may be very difficult to do task-based fMRI. We have even started resting state fMRI for even pre-surgical evaluation. But again, there will be an element of risk always looking at comparing these lesional WADA studies with excitatory fMRI studies. So another very important use of these resting state networks, which I'm not going into the details, is that looking at the epilepsy networks and nodes, even though it is in the experimental stage or a very advanced centers only are doing resective surgery based on network node analysis, but it is evolving in a very much better way. I think the role of this the resting state networks is detection of this resting state network is going to go further. So this is a case where you can see this is a subcortical as well as subependymal nodular heterotopia with this schizencephaly. You can see this patient, the language is luckily lateralized to the opposite side. And you see this, the arcuate fasciculus is definitely abnormal. Language is definitely lateralized to the other side. So they will go for a genetic testing, and if there is intractable, the surgery planning may these white matter tract as well as a functional reorganization may be useful for the surgeons. So another very important thing is that the 3D printing I told. So all these especially with the grids and electrode plate placements. After that, we can actually get the CT and do a 3D printing so that the surgeon will exactly know where it's actually coming from. With stereo EEG, I don't think these things may be very, very relevant. So what I mean to say is that it's a very dynamic field. Every day, more focal resective surgeries like laser ablation based on network node analysis is also happening. And the 10th rule is that nothing can replace teamwork. This is especially true in epilepsy work, because once you resect a lesion, you cannot actually put back. So you have to be 100% sure that you are actually not harming the patient. So with this, there is an algorithmic approach. So interactive epilepsy evaluation is we look at the images initially, but we should always have a discussion in the multidisciplinary clinical meeting with the clinical video EEG data. Then MR positive focal lesions will be again discussed mostly, and decisions for surgery will be taken. And then looking at the electron cortex and the surgeon wants, we will go for the advanced sequences. So when it is MR negative, again discussed in the epilepsy meeting, and then you can see that the further evaluations will be planned, including other higher functional imaging and invasive monitoring when it is required. So then decide whether this is a surgical candidate or non-surgical candidate. So once you do all those things, even then there can be failures. And so epilepsy surgery is a teamwork, and it is evolving, and every day newer advances are happening. And problem is that these advances are coming with a price, and many of them are not true technology. For example, every time your resection results based on advanced functional imaging may not be replicable from an advanced surgical center in the West. So you have to be aware of the limitations as well. And having said that, looking hard for these the substrates and looking hard for a curable lesion is always important. And thank you very much for your kind attention. And I'm sure that there are some questions.
Thank you, sir, for that wonderful enlightening presentation. So, sir, through his golden 10 rules, has taken through us to the points of protocols of neuroimaging in epilepsy, and also briefly introduced into us a few of the common causes of epilepsies in children. And also he has touched upon the dynamic nature and dynamic findings with respect to FCD, post-ictal state, as well as Varsmuth and encephalitis. And also he has enlightened us about the presence of clinico-radiological dissociation, especially explained by network pathogenesis of epilepsy. And also he has pressed upon the importance of interpretation of various neuroimaging findings on the background of clinical as well as electrophysiological findings. And also he has reinforced on the basic interventions or methodology like ultrasound as well as on the advanced neuroimaging findings of epilepsies, and briefly touched upon role of artificial intelligence in neuroimaging of epilepsies. So now I would like to invite comment from the panelists, and I would like to hand over the session to Rachna ma'am for a Q&A session.
I think Dr. Rachna is not there. Thank you, sir. Thank you for the excellent lecture. We have few questions. If MRI taken very early in very early in life is negative, considering the limited finances, what would be the optimal timing to plan the second neuroimaging in children with drug-resistant epilepsy?
I think given chance, I think because of the myelination maturation, which is happening after 1 year, 1.5 years. So if you have limited resources, I think one image should be after 1.5 years. That's what I feel. But having said that, if there is a possibility of early resection, we don't have to wait till that time. So 6 months apart, if 2 images are there, we can most of the time, even when the brain is, the myelination is not complete, we can actually compare and see there is a dysplasia, even though it will be slightly hard. So more than 2 years, it will be easier for us to diagnose on T2 weighted images, because the myelination will be expected to complete by that time.
For a non-radiologist, when seeing the images on a DICOM, how to narrow the window?
So there is the option in most of the DICOM viewers. There is an option of window leveling and window width adjustment. So for example, your radiant viewer, it's in the top panel, you can actually adjust it. And if you look at the user manual, you will find out. Otherwise, you can ask a radiologist to show that, because everybody will be happy to show you that. There is no secret in that.
Sure. Also, is arterial spin labeling software normally available with all 3T MRI machines?
No, it is, unfortunately, it is available with all 3T machines, but I don't know, but it is a very expensive sequence. And what we use is a sequence which is called 3D pseudo-continuous FSC sequence, and which is available with one vendor at present, but other vendors are also coming out with that. And 2D sequences may not be very useful. And the 3D sequence which I have shown is that the one which is really, really useful, and it should show the parenchymal perfusion. And if you're buying a new machine, it is worth buying with the new machine, because if you are buying it later, it will cost a lot of money. So if you're buying a new machine, I think you should include this sequence, because it is a very, very, very useful sequence if you're planning to do epilepsy work. And it's also useful for many other things, including pediatric tumors.
What are the minimal essential sequences that you will advise for any child with epilepsy? I think we've already discussed, but what is the role for DTI in children with a plan for epilepsy surgery?
So minimum sequence 3, I told already: 3D T1, 3D flare, and coronal high resolution T2. Having said that, many many MR machines will not have the capability of 3D flare and 3D T2 the way the harness protocol envisages, with the resolution which is required, especially when they don't have 3T. So at least one 3D sequence and a very high resolution T2 sequence and flare sequence should be there. T2 DTI, it depends on the surgeon. So even if you are very much interested in mapping out these the arcuate fasciculus and the corticospinal tract, and if the surgeon is not interested in looking at them, it will be very, very difficult. So surgeons will be interested in corticospinal tract and also arcuate fasciculus, especially when they are actually looking at eloquent area preservation. But the problem with epilepsy surgery is that once they go in, this is a do or die situation. So we have to, they are mapping the cortex, they are doing the EKGs, then they are interested in getting the seizure freedom, and especially in very young children, they believe in the brain plasticity. So they'll be more worried about seizure, completely taking out the network node or the substrate out rather than actually preserving this cortex, unless it is a motor function.
How successful are you in acquiring a fMRI in young children, sir, or children with intellectual disability if they are planning
Yes.
plan for a language or a motor function mapping?
Yeah, so that is a very important and interesting question. So when they're most of these children, like they will have an intellectual disability as well. So what we do is that initially we used to give them simple paradigms like completing a story, listening to a story. But the problem is that even then their language lateralization is not very reliable, because they may not be doing that paradigm correctly, because they should have basic level of intelligence to see that which is the foil and which is the active condition. So in order to overcome this, we have looked at the resting state networks also. So the resting state networks also, most of the time, we can give the lateralization very well. So like Smita has shown from our group, she has shown that it is really possible to do, even when the child is not really cooperative, we can actually do this language lateralization. Having said that, when the neurologists are not 100% sure about the language, except in very young children, less than 4 years, for example, so they will go for this thing when they are not very sure that whether their language lateralization based on fMRI is not correct. So, but in a young child, getting a propofol VADA is even harder. So it is most of the Western places, everybody is gradually switching on to resting state networks and looking at fMRI language lateralization.
Dr. Ananda Kesavan has asked a 11-year-old child with recurrent hemiplegia and seizures due to gangliocapsular AVM. Are there any treatment options from the interventional radiology perspective, sir?
Yeah, I think one of the indications is an intractable seizure, but even after embolization, there can be seizure continuation. So it depends on whether the resective surgery after embolization is possible or not. So another very important thing is that you have to make sure that this is AVM is causing these seizures. Most of the time it will be, but embolization alone may not be curable as far as the seizure is concerned.
After no detectable lesion on 2 3T MRIs done after 2 years of age in a child with a refractory focal epilepsy with a consistent focal EEG localization, what would be the next best mode of imaging?
So it depends on 2 years of age. After 2 years of age, so we are pretty much sure that this is an MR negative epilepsy, and then in our place, at least, we will look for, even if this is actually done 3T from outside, we will do 3D sequence with an ASL, because many a times we have found that the ASL will at least show a hypoperfused area that they can concentrate. So most of the time, when it is MR is negative, the next investigation they will go for, when they are very sure about the focal nature of the epilepsy, is a PET study. And the PET study, they will see that there is a hypometabolism is there or not. When that is also negative, when they are very strongly suggesting a focal lesion, then they go for invasive imaging, especially stereo EEG or grid placement. So if they are planning for a resective surgery.
What was the cause for hyperintensity of paleocortex compared to neocortex on imaging?
So initially it was thought that it's a flare artifact, but now we know that the pyramidal layer is there is no 6-layer cortex there. So it is a differential number of pyramidal cells compared to parenchyma, maybe the cause for this hyperintensity.
MOGHE, how we will call it on imaging? We'll just report it as FCD or MOGHE?
MOGHE cannot be diagnosed on imaging, which I told, we called it as a type 1 dysplasia. It turned out to be MOGE. So I don't think anybody can diagnose a MOGE specific, because it's actually a histopathological diagnosis. We can say that most of the time we may not even call it as a dysplasia because it is so difficult to diagnose.
Thank you, sir. Naveen sir, are there any further questions?
No other questions.
Okay.
And thank you very much.
Thank you, sir. Thank you for the excellent and simplified, well-organized talk. And I also thank Dr. Raghavendra for moderating the session.
Thank you.
Thank you very much.
Thank you, sir.
Bye.
So the next Wednesday we'll be having clinical grand rounds. The topic would be trouble at the junction and neuromuscular crisis. The presenters for this session would be Dr. Himanshu Gupta and Dr. Shagun from Department of Pediatrics, PGI Chandigarh. The moderator for this session is Dr. Renu Satta, Associate Professor from PGI. And the session experts are Dr. Naveen Sangyan and Dr. Sitara Ramdas. And this session would be coordinated by Dr. Mini Sridharan. I think we'll conclude the session now. Thank you.